If you're choosing a behavioral health EHR for an outpatient clinic, a multi-program organization, or anything in between, here's what you actually need to know. If you're running a multi-program behavioral health organization, outpatient, residential, or both, this is for you. Not a checklist, not a feature comparison, 5 questions that actually reveal whether a platform can handle the way your organization works. But first, one framing point on what you're actually choosing between. There are effectively 3 types of software competing for your signature in 2026. The first is a general medical EHR with a behavioral health module bolted on. Built for physical health and adapted, it checks most boxes in a demo. It will struggle the moment you need 42 CFR Part 2, data segmentation, SUD-specific workflows, or multidisciplinary crisis documentation. The second is a standalone behavioral health EHR, built for the clinical work. Good documentation, reasonable billing support, often telehealth. But interoperability, payer quality reporting, and population-level coordination, that's where the ceiling appears. The third, and the category that matters most right now, is a platform built to orchestrate care across your entire organization, with a behavioral health EHR at the core. The EHR becomes a command center, not a chart room. That distinction is what the 4 questions coming next are designed to surface. The first question may sound obvious. It is not. Almost every vendor in this space will tell you they are purpose-built for behavioral health. Ask them to prove it. Ask whether their platform handles 42 CFR Part 2 data segmentation natively, meaning SUD records are protected at the data layer, not managed through a manual workflow. Ask whether peer support specialist notes, crisis documentation, and group therapy billing are built in, or require custom configuration at additional cost. A platform that was adapted for behavioral health will answer these questions vaguely. A platform that was built for it will show you exactly where it lives in the system. The second question is specifically for organizations running or planning to run a residential program. Residential psychiatry is not a hospital module. The clinical workflows are fundamentally different. Milieu documentation, daily treatment plan updates, crisis event capture, multidisciplinary team notes, these workflows require a system that was designed for them, not retrofitted. Ask the vendor to show you the residential workflow live, not a slide, not a screenshot. If they need time to set it up, you have your answer. The third question is about compliance, and not the version that appears in a features list. In 2026, compliance for a mid to enterprise behavioral health organization means multiple things simultaneously. It means HIPAA and high-tech at the baseline. O&C certification and TEFCA interoperability requirements if you are participating in health information exchanges. CCBHC reporting across 8 required service types if you are operating under that model. And the CY 2026 physician fee schedule changes that expanded reimbursement for care management and chronic care coordination, all of which require documentation your EHR needs to produce automatically, not manually. Ask the vendor to walk you through CCBHC reporting specifically. If they pivot to a general compliance statement, you have your answer. The fourth question is where most platforms that look strong in a demo start to show their limits. Enterprise behavioral health is not one thing. It is a CMHC running outpatient therapy, a crisis stabilization unit, an SUD program, and a peer support service, often across multiple locations, billed to Medicaid managed care organizations, commercial payers, and grants simultaneously. Every one of those dimensions adds complexity. Most EHR platforms were architected to handle one of them well, Ask, how does your platform manage multi-program clinical workflows without creating separate siloed instances? How does your system support multi-payer quality reporting from a single data layer? If the answer involves significant custom configuration or additional modules, factor that cost and timeline into your evaluation. The fifth question is the one most organizations think about last. It should be close to first. Implementation is where EHR decisions succeed or fail in practice. Ask for the actual implementation timeline for an organization of your size and complexity, not the best case number from the sales deck. Ask what happens to your contract if the implementation runs over, and whether your data is fully portable if you ever need to exit. A vendor who answers these questions with specifics is a very different partner from one who redirects to a case study PDF. blueBriX was built to answer all 5 of these questions directly. It is a purpose-built behavioral health EHR and care coordination platform designed from the ground up for the complexity that mid to enterprise outpatient and multi-program behavioral health organizations are managing right now. 42 CFR Part 2. Compliant workflows built in, not bolted on. Purpose-built residential workflows. Milieu documentation, crisis capture, and treatment plan management designed for how residential care actually runs. CCBHC reporting without manual workarounds. Multi-site, multi-program, multi-payer architecture at the platform layer, and an AI orchestration layer that handles documentation and care coordination without replacing the clinical judgment of your team. It has supported more than 2.2 million patients across 12,000 providers in the US, and it is built to scale with where your organization is going, not just where it is today. If you are in an active EHR evaluation or approaching one, visit blueBriX.health to schedule a demo with our team. Bring these 5 questions. They will have answers.